All right. Good morning, everyone. Hi. Welcome to the Adolescent Reproductive Health Symposium. My name is Elizabeth Sayas, or Eb, and this is Dr. Brooke Boker, and we're going to be your co-directors for the event and your co-hostesses while you are here at Children's during the day. Should you need anything, any questions, concerns, or anything arises, please feel free to seek one of us out, and we'd be happy to answer any questions or concerns that you have. The Adolescent Reproductive Health Symposium was made possible through funding from the was made possible through grant funding from the American Academy of Pediatrics section on adolescent health and the Centers for Disease Control and Prevention. Its focus really is to help primary care providers feel more comfortable and confident in providing reproductive counseling services to teenagers, particularly in the areas of contraceptive counseling and increasing sexually transmitted infection screening rates during routine well child checks. Obviously, we hope that this translates then into decreasing teenage unintended pregnancy rates in the greater DC area. I'm sure that most of you have heard teenage pregnancy rates are on the decline and have reached record lows. So we have a 57% decrease in our teenage pregnancy rates from its peak in 1991. So we have made great efforts and great strides. However, we know that minority populations are still disproportionately affected by this. And we also know that compared to other industrialized nations, the U.S. is still ranking fairly high. So there is much work that needs to continue to be done. As a result, we are very, very happy that, sorry.
Taking a picture.
Oh, sorry. Okay. We are so happy that there are so many primary care physicians, nurse practitioners, physicians assistants, and medical students who are here in our audience who want to learn more about reproductive health and incorporate it into their daily practice. But we all know that this cannot happen within the confines of a doctor's office. And so we are thrilled to have such a diverse audience that is here today at our Adolescent Reproductive Health Symposium. We have representation from DC government agencies, from the DC public school systems, and from multiple healthcare services throughout DC. You guys are really on the front lines advocating for reproductive health care services for our teens. And so we thank you very much for coming. We hope that you learn a lot today, not only from the presenters that stand up here, but also from each other. So thank you for coming. Sure. So we just have one disclosure today. One of our presenters, Dr. Peggy Yee, who is actually going to be presenting and running the small group Depo-Provera and long-acting reversible contraception, does hold stock in Merck. Don't hold it against her, I guess. And then we have no other disclosures, financial or otherwise, to tell you.
Okay, so I'm going to take you through the game of today, the logistics and everything. For those of you who have come in, especially those from Children's, and maybe bypassed our registration desk downstairs, don't worry, we'll bring those badges and extra folders up. I saw somebody come in looking around. So we'll definitely help everybody out shortly with that. In the meantime, your folder, those of you that have them on the left side, many of you have already been reading through the resources that we have available for you to take home and share with others. On the right side of your folder, you'll see the agenda for the day, which I'll go through in a moment, as well as the biographies of the speakers. In the colored paper, everybody has slightly different color, is our end of the conference survey. So whenever the conference is over for you, we ask that in person you fill out that survey and hand it in to anybody at the back of whichever room you're landing in. It's very important to us, as well as our funders, the AAP and the CDC, that we get this feedback to them. And then the last piece on the right side of the folder is the CME information for those of you looking to claim credit. We have been accredited for 5.75 hours today if you're here for the entirety of the conference. The slides look something like this in your folder. You don't need to memorize this, that's why we put it in there, but it's just a website. You'll log on, set up your own registration account, and the CME access will be granted through Innova, our partner there. If you haven't heard, nurse practitioners in the audience, CME credits are now allowed to be used as CEU credits, and so our nurse practitioners are now allowed to get the same credits, so it's going to be an exciting day. Now for the agenda. Those of you who have already picked up a badge that's been pre-printed will have your assignments on it. Of course, we didn't think ahead. You'll have to look down at your own assignments. But those are for the breakout sessions, and we will remind you as the time comes around 10 or 10:15. Those of you who will be going upstairs for the OCPs and Upper Provera sessions, we'll instruct you to follow the person with the placard that says 5th floor or 6th floor, and we will have the security helping us with batching the elevator to go directly to the floor expedited. But at any time, you can use our elevator. For those of you not here in the system, please note that this is a different programmed elevator. You need to press the elevator floor that you want to go to, and it will tell you which number elevator to take. And then you don't need to touch any buttons. In fact, you can't touch any buttons. And it'll just whisk you there. So that will happen at 10. It'll happen again at 11:15. And then after our lunch, which is on the 5th floor, same elevator bay that everybody came up on the 5th floor will be lunch. We'll meet back down here in the auditorium, and we'll have one more round of breakout sessions. So we'll be here to help everybody move if you're unfamiliar. Anybody who is from Children's already knows to help everybody else find their way. But I think it's going to be an exciting day. For those of you who want more than water, you are welcome to get anything from the cafeteria on the drink spectrum. As long as it's covered, you can have that here in the auditorium. We are not allowed to eat here in the auditorium. We will be providing you a snack later this morning, but we ask that you eat that during your break when we're outside of the auditorium. Okay. Okay. Is it revised? All right. I have it in my little badge. Okay. Okay. So, why don't you introduce AJ? Okay. Sorry. So, our first speaker is Mr. AJ Cooper, and he is going to be talking to us about teen pregnancy, discussing the status quo nationally versus what's going on here in the greater D.C. area. Mr. Cooper is the policy director for the D.C. campaign to prevent teen pregnancy, and his advocacy efforts have resulted in the city's council HALF by 2015 resolution. This marks the first time that the city government has set a goal for teen pregnancy prevention. Other little-known facts, perhaps, about Mr. Cooper is that he is a proud graduate of the United States Marine Corps Officer Candidate School, and he was also the host of BET national syndicated television show Teen Summit. So without further ado, I would like to welcome Mr. AJ Cooper, and we will get to your slides.
Oh, sure. Is this the slide?
No, it's
oh, Mike. I think I'll be all right without the mic. Good morning. How you doing? All right. So early morning in the auditorium kind of gives me flashbacks to high school. So excuse me if I start acting like a nerd. So do I just click this for the slide?
We are going to get your slides up right now.
Okay.
Sorry.
While we're doing that, so what we're going to talk about today is a little bit of background on what's going on in D.C. How do we come up with the rate, and also some of the best practices to prevent teen pregnancy. But we're also going to talk about why is the rate falling so much nationwide, but D.C. falls a few points behind that. What's happening? Can you guys hear me? Can you hear me okay? Okay.
Then let's use it.
Want me to rock the mic?
We've got people online.
Oh, okay.
It's being recorded and live.
Okay. So all my online people, hello. Ready with slides?
No. We had our first technical difficulty of the day. We have our wonderful Brandy Williams in the back helping with everything.
All right. You're good. I feel high
like
tech
we're in LA.
now. All right. Okay, so in lieu of the slides, let's talk a little bit about D.C. and what's going on in D.C. So in D.C. we have a tale of two cities.
we have one side of the city that has the highest educated people in the country, some of the most wealthy neighborhoods in the country, and some of the best health outcomes in the country, bar none, and in the world, really. And then on the other side of the city, we have some of the worst educational outcomes. Ward 8, statistics say that adult illiteracy is 50%. Continuously for the past 30 years, less than half of the kids graduate from high school. The median family income is $30,000 a year for a family of 4. Health outcomes, and not just reproductive health outcomes, but health outcomes, period, are abysmal. Diabetes, hypertension, obesity, heart disease, cancer, all of these things are very prevalent on another side of the city. This city is very small. It's smaller than some boroughs in New York. And so the question that you must ask, why the difference in outcomes? And it's simple, money. One side of the city is very, very affluent and has access to all of the things that that affluence brings. The other side of the city is not affluent. And because of that, their health outcomes are much lower. But you say, but the insured rate in D.C. is higher than almost anywhere else in the country. Everybody's got insurance in D.C. Yes, that's true. However, that doesn't translate to a healthier, happier community, unfortunately. Because when you have generational poverty, problems compound themselves until you get a state where even with health insurance, folks are not getting the health care that they need and not getting the health education that they need. Now, I made all these pretty slides, and I wasn't going to go through them. But so before we, I guess while we're waiting for the slides and to keep everybody awake, does anyone have any questions they'd like to ask about DC campaign to prevent teen pregnancy or teen pregnancy issues in the city? So I won't kind of completely go off the ranch and then, there you go. There you go. All right, like to see it. Okay, so there's our lovely logo, DC Campaign to Prevent Teen Pregnancy. So our mission, cut the teen pregnancy rate in half by 2015. This was a bold mission. However, we had some history in cutting the rate because we set a goal in 1999 of cutting the rate in half, and we did that. And so when we set up this mission, we knew that we could do it if we could get government to coordinate correctly. In the District of Columbia, we have a lot of city systems that are funded to the tune of hundreds of millions of dollars, but they're not working together. And so you have DCPS, you have Department of Health, you have Department of Employment Services, you have TANF, you have a bunch of city systems that are all ostensibly supposed to improve the lives of residents, but they're working in silos. And so you'll have DCPS that doesn't have a coordinated reproductive health education curriculum. You have DOES that has a summer youth employment program where you have thousands of kids in it every summer, but they talk zero about teen pregnancy prevention. You have TANF that has its own issues that we won't go into. But the point is, if they work together, teen pregnancy is well within their ability to fix. And so part of cutting the rate is systems integration, making sure that DCPS, DOH, all of the alphabet soup are working together to cut teen pregnancy. And why is it so important? Because we know that there's a direct link between teen pregnancy and educational outcomes. There's a direct link between teen pregnancy and juvenile justice. All of these things are connected, and we can save the city hundreds of millions of dollars a year and improve outcomes for young people and adults alike. This is how we come to the rate. A lot of times when we're speaking to even agency heads and experts, they confuse teen births with the teen pregnancy rate and confuse the numbers. And so just to be clear, teen births plus abortions plus fetal deaths times 1,000 divided by the population of girls ages 15 to 19 is how we get the teen pregnancy rate. Now, this isn't a perfect equation, and here's why. All abortion providers aren't required to report their abortions. And so that part of the equation, we know that we don't have a complete number. But again, systems integration, it would be nice if they would all report so that we could get an accurate number so that we could do our jobs better. But this is how the rate is calculated. This was a 2010 rate, 54 pregnancies per 1,000 girls 15 to 19. This is the baseline that we used for our Hatch by 2015 resolution. We're close. We're close. 2015 is right around the corner, and we're close. And we've been able to get close because of a few factors. One, council members are starting to see that this is something that makes sense for them to be interested in. It's something that they can fix. And so council members have been more supportive of teen pregnancy prevention initiatives, specifically Yvette Alexander with the Committee of Health. This rate is still significantly higher than the rest of the country. And I believe that generational poverty in the district and the district is going through changes, as we all know. More affluent people are moving into the city, and so you would assume that that would be one of the reasons why we should have a lower teen pregnancy rate than the rest of the country. But what is really happening is the lower income to poor people, instead of just being moved completely out of the city, in Northwest, certain parts of Northeast, they're moving into Ward 7 and 8. And so those communities, rather than becoming more affluent, are just getting the poor people that got priced out of 4 and 5. And so the status quo is pretty much remaining as far as that goes. If you look at this map of the District of Columbia, all of these circles represent a teen birth. They represent a teen girl and her family that are going through all of the things that go along with becoming a teen parent. For families that are already living on the razor's edge, often this is enough to keep them in that cycle of poverty. This prevents oftentimes that young girl from either graduating high school, and certainly it makes it more difficult for her to go on to higher education. But as you can see, there's a dividing line in the city. This line right here is Georgia Avenue. And so you see, the further east you go in the city, the more prevalent the teen pregnancies are. The further west you go, not so much. Why is that? Generational poverty is part of it. Access to reliable, long-acting, reversible contraception is another big part of it. Things like LARCs really help prevent teen pregnancy, and it's not that teens west of the river are having less sex. It's just that they're better protected against teen pregnancy. They have a lot of the protective factors that children east of the river do not have, and we'll go into those protective factors a bit later. If you look at this map, this is a map that reflects juvenile arrests in the city. And so if you look back and forth, they fit like a glove with where we have teen pregnancies. If you did an overlay with low educational attainment, it would fit like a glove. Obesity, fit like a glove. Unemployment, fit like a glove. Child abuse, all of those things, because they're centered around places where we have pockets of generational poverty or financial insecurity. There's only two ways to prevent teen pregnancy, and it's pretty simple. It's not rocket science. Either you delay the onset of sexual activity until you're no longer a teen. That's a 100% guaranteed way not to become a teen parent. Now, the odds of teens delaying the onset of sexual activity until they are older than 18 is relatively low. In an ideal world, would we like them to all be, doing homework until they get to be 18 and save that? Yes. But realistically, teens are going to have sex. And so We need to accept that and make sure that they use effective contraception correctly every time they have sex. That means not only education for teens, that means education for the parents of teens. Because if you don't have parents as partners in prevention, then you're setting yourself up for failure. Parents are our biggest ally when it comes to teen pregnancy prevention. And so we should always focus on bringing them in and incorporating them as partners rather than dealing with the teen in a silo. Now, if you have a teen that might have parents that are disengaged, then they're mentors, the people that they are dealing with every day, teachers, principals, coaches, any of those recreation center employees, any youth-serving government employees or youth-serving folks in general need to be trained on teen pregnancy prevention and how to talk to teens about love, sex, and relationships, because what's worse than giving the teen no answer is giving the teen the wrong answer. And as somebody that, grew up in the city, I can remember the football coach giving advice that probably wasn't the best when it comes to teen pregnancy prevention. I can remember teachers giving some advice that probably wasn't the best advice. And so the adults that are in the lives of these children, we need to make sure that they're trained and prepared to talk to kids about sex and contraception. So these are some of the things that research says makes teen pregnancy less likely. I know that we're all readers in here, so I won't go through all of them, and I can make these slides available, but just to touch on a few. And they're all in the same vein of protective factors, the things that all children need. Connecting to their families, neighborhoods, having safe places to spend with adult supervision, spend time with adult supervision, health care, a plan that does not include teen pregnancy in their teen years. You'd be surprised, or maybe you wouldn't, how many young people don't have a concrete plan that does not include teen pregnancy. For a lot of these young people, they don't have realistic plans for the future. And kids are smart. They see what's going on around them. For a lot of these kids, they see that even the kids that do well in school are still in the same neighborhoods with them. Even the kids that don't get in trouble still end up having the same kind of outcomes that they're having. And so why not have fun when I'm 16, 17? Because when I get to be an adult, I won't be able to do it anymore. Why not have sex? What are the odds of me really going to an Ivy League school and becoming wealthy? What are the odds of me, doing that kind of stuff? To them, their perception is the odds are very low. I mean, imagine if today you knew that there would be no more advancement in the rest of your life. You would never make any more money. You would never get married. You never have a nicer car, any of that kind of stuff. And you would, you think that you would die in the next few years. Some people would start praying and be really pious. A lot of other people would be like, well, it's a party. I might as well enjoy it while I can. And that's the way a lot of these young people feel. You wonder, why do these young people steal cars, and why are they engaging in violence, and why are they having unprotected sex? It's because when there's no tomorrow, there's no reason to value today, and you might as well enjoy it while you got it. So that making a clear plan is key. Experiencing success in school and having a sense of belonging. So this is pretty broad and a basic overview, but one thing I want you to think about and remember, we're in Washington, D.C., the capital of the United States of America, and we've got an outcomes map that looks like that. If we've got those kinds of disparities in the capital of the United States of America, what can we expect in the rest of the country? If we can't get it right here in D.C., how can we expect them to get it right in New York, Philadelphia, or small town USA? As healthcare professionals here in the Capitol, we have a special responsibility to create models that can be replicated nationwide that work. And so I'll leave you with that, and if there are any questions, I'd be happy to answer them now. I think I have about 5 minutes. Yes. So the way the CDC does it is they have 10 to 13 and then 14 to 19. Thankfully, the number of teen births, 10 to 13, are low, relatively low. However, research shows us that teens are having sex earlier. And so you have 7th and 8th graders engaging in their first intercourse, which is something to keep in mind. But that's the reason why it's 14 to 19. Yes. Yes, sir.
Is your goal only to prevent unwanted pregnancy or also young girls who actually want babies?
Can you repeat the question?
So the question was, is our goal to only prevent teen pregnancy, or is it to prevent unwanted pregnancy in young people as well, correct?
No.
Huh?
My understanding, and I may be wrong, is that there are some young girls who actually want to get pregnant.
Uh-huh.
There are some young girls who actually want to get pregnant, and they may not realize all the consequences. So
right.
Do you work on prevention of that as well?
Right. To be clear, no teen pregnancy is okay because teens are children. It's not okay for a child to become a parent. And so even for the teens that think that they want to become teen parents, we want to prevent that teen pregnancy too, because there are young men who want to be a gangster and engage in dangerous behavior, and there are consequences with that. Every child deserves a childhood, and once you become a parent, you're no longer a child. These young folks, we want to encourage them and give them the tools that they need so that they can delay childhood until they're adults, hopefully until they graduate from college. And that's not to say don't have sex. It's to say protect yourself from the consequences that can happen through unprotected sex. And so, yes, if there's a 15-year-old that says she's in love and she wants to become, a mother right now, we'd say, listen, glad you're in love. The world needs love. I need love, okay? Protect yourself and make that choice when you're more financially stable to be able to do so. Any other questions? Yes, no, maybe so? All right, great. So if you do have any other questions, you can find me at DC Campaign to Prevent Teen Pregnancy. You can check us out online at dccampaign.org. Thank you so much for having me and being such a great audience this early in the morning. Thank you.
I apologize for all of our technical delays today. I blame the resident roast that happened in here yesterday. It was just too much fun that they had, and so broke computers and all sorts of stuff. So we're working on getting everything up and running. Our next presenter is Dr. Kathy Woodward, who has been here at Children's National Medical Center, as an attending since 1983, but she also completed both her residency and adolescent medicine training here as well. So she has been a figurehead in our department for over 30 years. I don't know anybody else who cares so much about the health of teens and who speaks so eloquently to our teenagers about their reproductive health needs. So she is going to speak to us today about understanding confidentiality in Washington, D.C., Maryland, and Virginia.
Good morning. It's good to see you all. The first statement is there's a difference between confidentiality and consent. And so when we talk about healthcare issues in the district, part of it is consent for young people. So that has a lot to do with why we've been making gains in some areas, but not gains in obesity and asthma, because teens cannot consent to general medical care until they are 18. They cannot consent to immunization until they are 18. And so the consent laws probably have a bigger emphasis on access. And then confidentiality. As healthcare providers, we're used to doing confidentiality. And as pediatricians, we're used to working with parents. And we're used to sort of phrasing things differently. What we need and what the AAP needs to continue to work on with all the other professional organizations is talking about confidentiality for reproductive health with insurance companies. Because now that Obamacare is letting all these young adults up to 26, legally adults, should be entitled to their full confidentiality, but if they're on daddy's plan, he gets the EOB and sees her pap smear, her chlamydia test, and all her other sorts of things. He gets the statement from the pharmacy and the drug company talking about her birth control pill or whether she got a LARC or IUD, and again, that is not protected. So we still have a lot of work to do in terms of talking about confidentiality. So hopefully we're going to talk about identifying why confidential is essential to adolescent care. We're also going to talk about the laws regarding minors' access to reproductive health services, and maybe a little bit about sort of the legislators, since we're surrounded by political types here in D.C., how mandatory parental involvement laws sometimes affect adolescent health. We are very fortunate in that we have one of the most progressive areas in the Northeast, as the liberal press and Fox will tell you every Sunday. But confidentiality in adolescent health care is clinically essential, it's developmentally expected, and it's supported by expert consensus. So, clinically essential. In a clinical setting, confidentiality affects the adolescent's decision to seek care, disclosure of behaviors, follow-up care. And so all of those are really important in terms of determining health outcomes. For better clinical care, obviously there was a high school study done, which again, where students received randomized assurances of confidentiality or no assurance. So, some students got the confidentiality, some students didn't get the assurance of confidentiality. What were the rates? So 47% were willing to disclose information to the provider, and 67% were willing to come back for follow-up care. For kids who didn't get that piece of paper talking about their assurance of confidentiality, again, there was approximately a 10% difference in terms of willingness to disclose information. Luckily, kids did still come back, but again, it was more than a 14% drop in terms of those kids willing to come back for follow-up care from our adolescent colleague, Carol Ford in JAMA. So, another study of Massachusetts schools. And again, 76% of the students wanted the ability to obtain confidential health care, and only 45% perceived that confidential care was available to them in Massachusetts. It's developmentally expected that we're trying to teach them what confidentiality is between a health care and a patient. Again, there's this emotional need for increasing autonomy. Obviously, you've seen most in our middle adolescents, those sort of 15 to 17, right at the time that we give them a license. Interesting thing. 2 tons of steel going 65 miles an hour. Increasing intellectual capacity to give informed consent exists. And again, the opportunity to take responsibility for their health. And so we are using that developmentally approach to try and talk about introducing our teen portal here for our electronic record. If we look at the multiple professional organizations who support confidential adolescent health care, they've been on record for a long period of time of supporting this. So, parents are not the enemy. Parents are experiencing their own adjustment to having an adolescent. Providers have an opportunity to educate parents about the need for confidentiality in the provider-patient relationship. So, again, inform parents about confidentiality before the visit. So we have a process here that our pediatric clinic goes until 12. And then magically at 12, you get put to the other side of the wall in the Adolescent Health Center. We don't do a great job transitioning on the 11-year-old physicals that your 11-year-old physical is here, your 12-year-old physical may be over there. And how is it different? So we certainly are looking at trying to do more, especially with the electronic portal, as their birthdays come up, since the computer can find those things easily. Try and send them a letter about what's different about the Adolescent Health Center, what's different about puberty, trying to talk about giving parents more information about the changes that are going on and why confidentiality is important. Many practices send a letter home to sort of talk about that. Some post signs and information in the waiting room and detail when the parent will or will not be included in the clinical visit. I generally draw the line at the time that they need to change their clothes. Most teens, especially early adolescents, are getting, I'm on. I don't have my boxers on. Again, they want their privacy around their bodies. So that's the perfect time. I don't stay in the room when they change. Why should you stay in the room when they change? Why don't you go on out to the waiting room? They're going to change. I'm going to do the exam. We'll bring you back in. So those kinds of things in terms of talking about including the parent. And then for the teen, you've got to tell them billing issues. I don't have to tell them about your sexual activity. I don't have to do anything, but there may be some things that, again, may disclose. And so generally, for me, that's about 30% of my teens who have private insurance. There is the possibility that you will read the EOB. Now, you and I, even healthcare providers, sometimes don't read our EOBs. So you can imagine non-health parents probably don't read their EOBs either. As long as it's not a bill, and usually the insurance companies will say that right on the envelope, this is not a bill. This is not a bill. So open it and read it maybe. But again, the billing issues in terms of routine STIs. The other thing we need to tell teenagers is that STIs are reportable, mandatory reporting. And so you need to make sure that we have a working cell phone number or you call me back to get your test results, because if your test goes untreated, the STD Bureau has a mandate to come find you and get you treated. They're not going to be able to talk about your confidentiality with their mandate. Now, there's so many chlamydia cases, they're overwhelmed, and I almost never see the chlamydia worker. But I can tell you the gonorrhea worker usually has more things, and they're definitely down on syphilis. They will find you. They will hunt you down and find you. We even had people go to schools or go to the school-based clinic and ask the principal or the teacher to send them from classroom to the school-based clinic, at least a confidential setting, to tell them about the need to be treated, and hopefully they can maybe get treated in the clinic. So again, there are limits to confidentiality. We face this as adults, and they face this as teens, and we sort of have to do that as part of their education. Again, a lot of times this assurance of confidentiality can be done by displaying materials that talk about the importance of the doctor-patient confidentiality, and developing their young health consumer is why they're going to leave the room. This is a posted statement from the medical department at the military office, hospitals, URMC. And again, our discussions with you are private. We hope that you feel free to talk openly with us about yourself and your health. Information is not shared with other people unless we are concerned that someone is in danger. Again, that's the other mandatory reporting. Healthcare providers, teachers, police officers are mandatory reporters for child abuse, physical and sexual. You are also mandatory reporters if someone is suicidal or homicidal. That poor psychologist with the Colorado shootings is facing all kinds of things. I don't know about the mental health person from the Santa Barbara person who shot people up in terms of what is your duty to warn. And then again, how do we as society respect adults who've been warned about suicidal and homicidal ideation. So again, there are limits to confidentiality. And so that's the other reality we have to let people know about. So, again, mandated reporting, abuse and neglect, concern of imminent harm for self or others, insurance billing, discoverable medical records, and validity of signed office agreements in terms of how much you can go. Again, this relationship between consent and confidentiality is a very difficult one. There are state and federal laws about confidentiality and consent. Consent laws may or may not address confidentiality in the statute for each state. Minor consent laws often contain provisions regarding confidentiality and disclosure. Other laws contain confidential provisions, and consent and confidentiality are linked in clinical practice, ethical guidelines, and professional policies. So legal rights differ by states. State-by-state factors affecting rights. What is the legal definition of a minor? What are the conditions in which a minor can petition the court to declare themselves an emancipated minor? What is parental notification and consent requirements? What is mandatory reporting requirements for your state and jurisdiction? So, when is care confidential? The authority to consent is not always means that care is confidential. When can providers break confidentiality? Abuse, risk of harm to self or others. Who is a minor? Well, that's pretty standard every place. And in most states, a minor is a person under the age of 18. Apparently, there are some states that will try and let you enroll in the military below 18, but I think the military is sort of changing all of that. So the good news is all 50 states and the District of Columbia does have the right for you to go to court, find a public assistant lawyer who will file your brief for emancipated minor status. And again, there are some conditions and there's some services, and then there's laws about being able to have your general medical care turned over to you. The mature minor doctrine was one of the things that the court developed to talk about the emancipated minor, and again, it's included formally in some state laws, not everyone. The capacity to give informed consent is considered, which is where, again, you're seeing the case down in Virginia of the young woman with Down syndrome who no longer wants to live with her parents and wants to live somewhere else, and so now that's in the court about, what her rights are, because, again, when your IQ is listed as below 80, it generally means you need guardianship, which means you cannot have the capacity to determine informed consent. Again, was this a voluntary decision? Again, we're talking about all medical care if you become an emancipated minor, not just reproductive health. And again, that there's no negligence. The parents can't sue on the minor's behalf. The minor is indeed acting as an adult. So legal emancipation, again, state-bound, all 50 states. Some of the conditions can include that, again, if you're married, if you're serving in the military, you lied about your age and got in, and you're serving in the military. Being financially independent is a big one with all the states. So other than Jaden Smith, I don't know anybody else who's probably financially independent enough to say that they want to be emancipated. I don't think it worked for, what's the guy, Home Alone? Him. So other than that, those are the big ones who sort of can have enough lawyers, agents, and other things to do that. And obviously, just when you say going to court for most teenagers, it kind of is a big block. So all three jurisdictions, D.C., Maryland, and Virginia, do allow teenagers to go to court and be declared emancipated. So again, making sure you know who your law schools are, and again, whether they offer any sort of free services for doing things like that. Consent is often based on status. So again, are you an emancipated minor? You got the court papers, you're it. Again, are you married? Again, some states will recognize marriage as a reason to give you emancipated status. Minor, again, in the armed services, unless you lied about your age, you're probably not in there as under 18. Are you a mature minor? Are you living apart from your parents? Some places, states want you to have graduated high school, because usually if you graduate high school, you'll be able to have financial means to support yourself. Some states will say over 16 as opposed to 18. Are you pregnant? Are you incarcerated? Other sorts of status things vary by state. The good news is for all of you working at Unity clinics who are Title X funded, and some of the other clinics, Clinical del Pueblo and Mary Center, thank you. If a clinic is Title X funded, services must be confidential. So the feds excluded themselves. I'm not sure how they got through Congress, but they did. And again, this federal exemption preempts state statutes. So if there is a family planning clinic in Utah, it's the only place in the state where teenagers can get confidential services. So what about in the District of Columbia? So in the District of Columbia in 1965, when we didn't have a representative in Congress, the early city council that was elected by the local officials put together the emancipated minor statute that exists today. And so what they did was our status is based on services. So as you can imagine, for us in reproductive health, that's a lot of services of what we do have been covered here for teenagers since 1965. Any pregnancy-related care, you are now emancipated. The bad news is the minute you drop that baby out of your vagina, you are no longer emancipated. Just the state, pregnancy. Just the state, pregnancy. Again, there's not a formal statute about contraception, but there is a thing for any DC health facility has to offer confidential care to family planning services regardless of age. So the lawyers interpret that as that all of family planning is covered as well. STD, VD prevention, diagnosis, and treatment is covered. Reportable disease prevention, diagnosis, and treatment is covered. HIV/AIDS testing and treatment, drug and alcohol counseling, outpatient mental health services, and again, you can be treated for sexual assault without parental permission. So, all 50 states, including the district, allow minors to consent for testing and treatment for STIs. Oops. Several states do say that you have to be at least 12 or at least 14. And that is the case in the district because if a person 12 or under has an STD, the health department automatically reports that to Child Protective Services because that's the child abuse law mandatory reporting. But if you're 13 or over, then obviously the Child Protective Services did not get involved. The health department stays in your business with all positives. So more than 60% of the states have explicitly included HIV testing and treatment in the package of STI services, similar to what we have in the district. Iowa is the only state to require parental notification in the case of a positive HIV test. DC, Maryland, and Virginia allow testing and treatment for HIV without parental consent or notification. Contraception and family planning in all 3 jurisdictions allows a minor to consent just like an adult for treatment and advice on contraceptive services except sterilization. So everything but sterilization they can consent to, including LARCs, IUDs, all of that is covered under that. Prenatal and obstetrical services. All 3 jurisdictions allow a teenager, a minor, to consent as an adult for treatment of pregnancy, prenatal care. We will come to abortion. In D.C., we have the most liberal one. Again, it's all states of pregnancy. So a minor can consent like an adult for a lawful abortion from 13 on up. Doesn't have to have a parent, doesn't have to have anybody else. The main thing, though, is you need the $375. So in most cases, most 13-year-olds are looking for somebody else who has $375. So that's where, again, for most early adolescents, there is usually a parent involved or a family member in terms of assisting them. In Maryland is one of those kind of, technically, a physician may not perform an abortion without giving notice to a parent or guardian unless the minor does not live with the parent or guardian, or 2, every reasonable effort to reach a parent or guardian has been unsuccessful. They also give an out for the provider. The physician may perform an abortion without notice if A, notice to the parent would lead to abuse of the minor is mature and capable of giving informed consent, or 3, notification is not in the best interest of the minor. And it's been about 10 years since I've had to write a letter to an OB about why it would be important for this young person to have a termination of pregnancy without their parents being involved in terms of their mental health issues or family crisis. But I haven't had to write that letter in about 10 years, so I think things have been relatively relaxed on that. Now we get to our wonderful state of Virginia. And this is where the leather hits the road. So abortion requires parental consent, written and notarized. How many teenagers know how to find a notary public? Okay? Notarized. So if you're not bringing your parent in with you and you have a written consent so you can't write your own note, please allow Sally to have an abortion. And then sign your mother's name. It's got to be notarized. if the parent's not there. You can also go to court and say that you don't want to ask your parent, but you're going to ask the judge. Now, how reasonable is that? Your judge is less intimidating than your parents? Really? But you can. And again, because of this judicial override, that made it fair to the U.S. Supreme Court. And again, you also have to make sure the minor has sufficiently mature and informed to make a decision, or that the desired abortion is in the minor's best interest. Neither parental consent nor judicial authorization nor notice is required if the minor is abused or neglected and the attending physician has reason to suspect that the minor may be abused or neglected. So obviously the rape incest thing does not require parental consent or a judicial overlay as long as the physician is reasonably certain about those allegations. So mandatory parental involvement. There are 4 studies that sort of measure this kind of mandatory parental involvement, particularly around abortion, notification, and consent, between 1986 and 2006 in Minnesota, Massachusetts, Mississippi, and Texas. So if you look at the abortion rate, and I'm sorry, but the dark arrows, the arrows did not show. But abortion rates did go down in all 4 of the states that had mandatory notification. They did not measure the teen birth rate in Minnesota, nor did they do it in Mississippi. And when they looked at it in Texas, the teen birth rate did go down slightly. And when they looked at it in, the middle one was Massachusetts, the teen birth rate did go up. And in Texas, in some populations, the teen birth rate went up when the parental notification happened. They looked at interstate travel. They did not look at interstate travel for abortions in Massachusetts and in Texas, but when they looked in Minnesota and when they looked in Mississippi, interstate travel for abortion services did go up in those 2 studies. If they looked at second trimester abortion, it did go up in Mississippi, and it also went up in some subpopulations in Texas. So it looks as if, yes, the rates go down, but some of the complications associated with it tend to go up. Ooh, I'm sorry, down, down, down. Sorry, I don't like to use graphics. All right. So that is sort of the state of where we are in terms of consent and confidentiality. And so for reproductive health, we're pretty much covered in all 3 jurisdictions. The good news is for most of Virginia, they are close enough to the District of Columbia that you can do that interstate travel and come across the road and have your procedure done here. And no one asks you where you live. Now, the Virginia people got hip to this. And so there have been several measures down in Richmond about trying to, again, talk about if boyfriend's mother drove you across the state line, she could be penalized and have to face criminal charges for transporting a minor across the state for purposes of abortion. So it's like, hi, honey, I'm taking you to the Boston station. From Boston, you'll get off at Metro at Farragut Sink, walk to the Planned Parenthood. I can meet you at the Planned Parenthood and hold your hand. But I can't transport you across state lines. So Virginia is probably the most. I've done a lot of talking. I do have a handout which has just the basic things about D.C., Maryland, and Virginia in the back if people want to pick it up. It also has this resource list so you don't have to write everything down. One of the ones that I think is probably the most important, what did I do? I was trying to get the pointer on. I found that, but I've done something else. Let's see, go back. Okay, so this Center for Adolescent Health and Law is Abigail English's organization, and they have a wonderful, wonderful slides. They do state by state. If you got to move and look for another job, you should find out what the state laws are before you move to make sure it's a place that's going to fit your style in terms of working. Obviously, the AAP has been very active in terms of adolescent confidentiality of consent. So has the Society for Health and Adolescent Medicine, ARHP, Advocates for Youth. There are many, many, many that have been very, very positive about giving resources. Back. Okay, so I think I have some time for questions.
Yes, definitely. Let's use the microphone so it can be recorded.
So for abortion providers that choose to use the loophole that they think the child is endangered or a victim, aren't they also mandated reporters? So wouldn't it then also still end up in a
So again, the loopholes about reporting abortions are very different. As the campaign was talking about, it's hard to get teen abortion rates because private providers do not have to report the abortions performed. So mandated abuse. So generally, again, if some of these, if there's been a case on file, if they get referred from the sexual assault center that they've diagnosed a teen with pregnancy, there's criminal investigation going on alleging assault, then they have a reasonable reason to suspect that there is true abuse and they can perform the procedure. In the District of Columbia, obviously, we find that same situation in some of our sexually abused young people. I have to tell you that I believe in forensic evidence, but I think it's a little difficult. But in some cases, since you're not going to go through the pregnancy and there won't be any baby to do gene testing on, the police officers actually come to the women's clinic and collect the fetus to do DNA on. So yes, there's sometimes, again, you're going to go to Planned Parenthood. Some of our immigrant populations who don't have any insurance, again, the fund is going to pay for it. But since this was a gang rape from your gang initiation and they kind of want to press charges, the police officers will also meet you there because they have to take chain of custody of the fetal products. So even though you bypass parental consent and you bypass court in Virginia, there still is that sort of forensic piece that sometimes happens associated with reported cases of abuse and neglect. Especially if you're going to try and charge the father for incest, you got to have evidence. So most people just come across into the district. Thank goodness we're close. Much harder in other parts of the country where there are very few abortion providers. Yes?
I have a question about, you said that during pregnancy in D.C. that the mother can give informed consent during that time, but then after birth, so a 17-year-old mother loses that ability for informed consent?
Until she turns 18.
But she can still make informed consent for her
baby. She always has the informed consent for her child.
And is that just D.C. specific?
No, that's pretty much everything. You are the parent of that child, so regardless of your age, as long as you are a mature minor. If you were special needs, some other sorts of things, sometimes the state will grant guardianship to a grandparent because, again, you are not fulfilling the mature ability and the ability to have informed consent. And so sometimes in special situations like that, you don't retain the ability to be the guardian for your parent.
I believe in Maryland, parent of a teen parent can consent for their own vaccine. That's one difference. Yeah, so that was my question is, while the woman is pregnant, is she able to just consent? My understanding was just for her prenatal care and pregnancy-related things, but we still needed
well, since most of her general health is related to her pregnancy, if she needed to go see a consultant, technically, she should be able to sign her own consent form in terms of if you sent her to an endocrinologist or had an abnormal glucose tolerance test or, again, had to go to the cardiologist because of preeclampsia. Theoretically, she can. Many of the adult specialists sort of aren't as aware of the ability to do that, and so sometimes they will still suggest that an adult come with them.
Yeah, I mean, I think the most common situation is for vaccines. That
the downside, though, is unless the vaccine has been around for a while, the ACIP, American College of Obstetrics Practices, tells you that you really can't give a lot of vaccines during pregnancy. Right now, you're not supposed to get HPV during pregnancy. You can get flu. You can get the Tdap with the pertussis. So that's all sort of covered. But everything else, they want you to wait until you're not pregnant. We don't need parental consent to get the Tdap for pregnancy. No, you don't. That's covered. All righty.
Thank you.
And while we're waiting for our next speaker to come up, is there anybody who doesn't have a folder yet? I know a few of you don't have a name badge. Great. And for those of you who don't have a name badge, we'll make sure to get them to you. Do you need another folder? Sure, great question. So for those of you who don't yet have a name badge, at the break after this speaker, then we'll make sure to get those to you. And at that time, we'll have some snacks and water in the back. And there was a question about slide availability. And this whole seminar is being WebEx recorded, so it'll be available for viewing in the future. And I'm sure that we can make the slide sets available independently if you want them. But the video themselves with the speakers will be available on the DC AAP website, and we'll make sure to send that link to all attendees.
So it's my pleasure to introduce our next speaker, Ms. Carlene Townsend-Akpan, who has been here at Children's National Medical Center for just over 40 years. During her 40-year career here, she has served in many, many capacities, but really the common theme throughout it all has been her dedicated to adolescent health, particularly those teenagers who have HIV and AIDS. When asking Carlene what she wanted me to include in her biography today, she said that she wanted to make sure that I included that she was the proud mother of a little Yorkie named Duke. And I said, well, what about your husband? How many years have you been married? And she was like, 20. So without further ado, here is Ms. Carlene Townsend-Akpan, who's going to be talking to us today about setting the stage for contraception.
Thank you so very much. I told Dr. Zayed, please don't let me follow Dr. Woodward, please. But of course, they did it anyway. So I am going to talk about setting the stage for talking with the adolescent about birth control and about doing a sexual history. So by the end of my presentation, you'll be able to discuss the elements of a medical and a sexual history. We'll skip those because that's not my part. I have just a few slides that I wanted to share in terms of the decline over time in teen pregnancy. If you look, from 1990 to 2006, there were about 117 per 1,000 teen pregnancies in the United States. That decline by 2006 was down to about 71.5%. And as of 2010, we're down, as the other gentleman spoke, to 54 per 1,000. So we have seen a significant decline in teen pregnancy over time. And why is that? Why are we seeing this decline? In 2006, there was an analysis done in the American Journal of Public Health that looked at that decline in 15 to 19-year-olds. And what they found was that 14% of that decline was due to a decrease in sexual activity among teenagers. But more important, 86% was due to the increase in contraceptive use among teenagers. One of the things that's not reflected in this slide is the access to health services that teenagers also had. The increase in that access is another reason why we're seeing that decline. This slide sort of reflects what we were seeing in adolescent females who had sex for the very first time and what kind of method of birth control did they use. If you look early on, before 1985, it was really basically no method at all they were using. And then as you got to 2005, 2008, it was down to about 16% who said they did not use a method at all. And you also see the increase in condom use as well over time. More kids were likely to say that they did use a condom at the time. And it's actually up to closer to 80% of teenagers who are now saying that they do use condoms. In looking at males who had sex for the first time, it's sort of similar data. No sex, no method whatsoever early on before 1980, and then up to about less than 13% who were saying that they didn't use a method at all. And as you can see, the condom use did go up as well during that time. Certainly since 2002, we're really seeing more and more teenagers who say that they are using condoms. So how are you going to talk to your teenager about contraception, about birth control, if they want to come into your office to discuss that? Angela is the 16-year-old who made an appointment to come in to talk about birth control. She indicated on her form that she uses condoms some of the time, or most of the time, sorry, most of the time. So what do we know about Angela before we even met her? That she's sexually active, yes. What else do we want to know, though? What additional information do we need to know about Angela? Anybody? No? How many partners? Okay. Anybody else? Smoker, non-smoker. Pardon me? Not already pregnant. Exactly. Make sure she's not already pregnant. Absolutely. So one of the basic components of talking with teens about contraception is there are two components that we need to focus on: the medical history and the psychosocial history. So if you look at the medical history that you want to take on your teenager, what is it that you want to know? You want to have a good handle of her menstrual history. How old was she when she first had her period? When was her last period, obviously? How long do her periods last? Are they heavy? Does she have clots? Are they regular or irregular? How long is her cycle length? Now, certainly with our young people, they're probably not going to know that. They don't generally know how long their cycle lengths are. And this is a teachable moment at this point, because you can certainly have them do a menstrual calendar for you. And many of the kids carry around their cell phones, and they download these apps for menstrual calendars, keeping up with the dates of their periods. So this is a very good teachable moment to get them to sort of figure out between one period and the next how long that is. Whether they have cramps or not may impact their activities, and may also lead you to sort of look at the different methods of birth control that would be available for them that would help in this area. In addition, you want to find out if they've had a history of deep vein thrombosis or pulmonary embolism. We actually did have a teenager who was pregnant and had a PE at the time. So certainly you want to get that history from your adolescent. Migraines, common in young people. With aura, a focal neurological deficit, you want to find out about that, because that'll impact on what method you might choose for that particular teenager. And then a personal or family history of blood clots. You want to find out about that, because then that may steer you to do a workup for clotting disorder in the young person. And then prior experience of contraceptive use. What have they used in the past? You want to get that information. So the medical history is very important. It'll help you focus on the types of methods that are available that you can use for that teenager. This is a very busy slide. You do have a copy of this in your folder, so don't try to see every little detail. But I put this up because this is a summary chart of U.S. medical eligibility criteria for contraceptive use. And we were just talking about deep vein thrombosis. So what this is if you look across the top, it talks about the different methods of birth control that are available. If you look down the side, it gives you common conditions that may happen. And then the green talks about methods that you can use with no restriction whatsoever. The light green, well, the dark green, the light green talks about methods you can use where the advantages sort of outweigh the risk. The pink talks about areas where the disadvantages sort of outweigh the advantages of using that method. And then the red is you can't use the method at all. So if you looked at deep vein thrombosis, you would see that you can use a method of birth control with them, but you have to wait for 3 months. Make sure you get them on an anticoagulant before you determine what method to use at that point. Most of the methods are okay to use after that, even if it's high risk that it may occur or low risk that it may occur, but the one area that you don't want to use, the one method you don't want to use is the pill. So that's generally what this slide sort of represents of the different methods, and it's very helpful to keep on hand when you're trying to decide what method to start your young person on based on the history that you have. So let's look at Angela's history. She's a little unsure of her medical history, not uncommon. You have a teenager coming into your office. She generally comes alone to seek birth control. She may not have a good history that she could give you about the family. She may not live with a relative. She may live in a group home. Or even if she lives with her family, they may not talk about you know, the dynamics of the family, the medical history. Sometimes grandma doesn't want people to know she has diabetes or high blood pressure. So the teenager generally doesn't have a good handle of their family history. And so Angela's a little unsure of her history, but she doesn't think that there's anybody in her family that has blood clots, basically. So you've done your medical history. What's the next thing to do? Psychosocial. Very important to get this history. When you do your psychosocial history, you can use a tool that we use in our clinic called the HEADS assessment. A very, very important tool to use with adolescents because it covers all the areas that you want to cover that will look at mortality, morbidity and mortality among teenagers, as well as sexual activity, as well as sexually transmitted diseases, as well as contraception. So a very good area to look at. And it starts from the least, sort of the least threatening to the young person. And what you're doing is you're setting the stage. You're trying to get them comfortable with the more sensitive things that you have to talk about later on. And in that process, you're trying to establish a better rapport so that they're more likely to confide and talk to you about more sensitive areas. So, of course, the HEADS assessment includes home, H for home, who do they live with, who's in the household, is mom's boyfriend may be there, so there may be some questions you may want to ask. Does she feel comfortable, you know, coming out of the shower, not running into mom's boyfriend? Some issues around that. Who does she sleep with? Does she have her own room? Or does she share a bed with someone? I had a young man who came in the other day with back pain. And in talking with him about where he sleeps on the couch. He doesn't have his own room. He doesn't have a bed to sleep in, but he sleeps on the couch. So that sort of gives you a lot of information. Education and employment. Are they in school or do they drop out? What kind of grades are they getting? You know, are they being bullied at school? How comfortable do they feel? Some teenagers work after school and work on the weekends. That can affect their education. So that's a good way of sort of getting more information with your teenager. Exercise, I always talk about this, is a lot of our kids are overweight. And do they exercise? It's another teachable moment to talk about the importance of exercise with your young person. Activities, basically, what are they interested in? What do they like to do? And you can get at a lot of things that teenagers have that they're thinking about, like I want to be a musician, I want to be a dancer, but kind of like sort of explore the activities, things that they like to do. If they don't like to do anything but stay in their room with the lights out, then of course you're going to focus your history on depression. So those are the kind of things that you're trying to get at. Diet, do they skip breakfast in the morning, or you know, do they eat 3 meals a day? Do they get their vegetables in? Do they drink water? So these kinds of things you want to ask under diet. Of course, depression. There is a depression screen that's done annually with our patients, but certainly at any visit you want to sort of assess that. Drug use. You don't want to just ask, do you use alcohol, marijuana, cocaine, but you want to be very specific with them because they'll tell you no, especially if they just do it once in a while. They don't consider that. And the thoughts that are going in their head is that you're saying that they do it all the time. That's what they hear when you ask. And they don't do it all the time, so they'll say no. So you can explore that a little bit more by asking, You know, have you experimented? Have you tried? And they're more likely to answer that question for you. The area that I'm going to focus on today is sexuality, so I'm going to skip that and talk a little quickly about safety. That has to do with seatbelt use. That has to do with protection if they ride their bikes. Do they wear helmets? Do they wear knee pads? Those kind of things. As you can see, the HEADS assessment didn't start out with all these areas. We kind of added and added over time. But this has been around since 1972. It was developed by physicians. And so, you know, us adolescent people like to sort of add and add. So we added areas on spirituality and strengths. What are their strengths and weaknesses? And you can sort of get at that by asking the teenager, you know, what do you see as your strength? What do others see as your strength? What do people like about you or dislike about you? So there are areas of exploration that you can do in that area. So let's focus on sexuality. One of the things that you want to focus on when you're doing a sexual history is the sexual orientation and gender identity. You don't want to assume that when you have a female sitting there, you're going to ask her, do you have a boyfriend? Also, you don't want to ask a male, do you have a girlfriend? So you want to be very, very specific about who they relate to. So one of the ways that you want to do that is you want to say, are you having relationship or sexual relations with male, female, or both? And that generally gets at the question that you want to ask. And they're more likely to answer that question than not to answer that question. I give them the opportunity not to answer a question if they feel very uncomfortable about it. They have permission not to answer it. And some of the questions you may not want to ask. You may feel a little uncomfortable. But over time, when you're doing your sexual history and establishing a rapport with that young person, you become more and more likely to ask, and they become more and more likely to share the information with you. History of vaginal, oral, or anal sex. Now, this is another area because they may not understand what you're talking about. So you may want to explain penis in vagina, penis in the mouth, penis in the bottom or in the butt. You have to be very specific with what you mean by that. The age that they started to have sex. Teenagers tend to be, females tend to be serial monogamous. They average about 4 partners a year. So certainly you want to ask when they started having sex because you can get a general idea of where they are in terms of numbers. I don't particularly ask about numbers. Some people do and some people don't. I think the reason why we ask about numbers is sort of determine whether or not we need to screen them, you know, more often than others who only have one partner. I think the teenagers are at risk, period, whether they have one partner or 6 partners. So my intervention with them is to talk about risk reduction as if they have a lot of partners. So I talk the same way about someone who has a lot of partners as well as I do with someone who only has one partner. So that's up to providers to kind of determine that, but that's how I feel about it. Pregnancy history. Have they been pregnant before? And also when Dr. Wood was talking, it's very true. You also have to find out if they want to protect themselves against a pregnancy, because some young people will tell you that, well, I'm thinking about going on birth control, and if I get pregnant, it won't be a problem. It doesn't matter whether I get pregnant or not. So it kind of gives you an idea, and they may not be good at the birth control method for long, but it kind of gives you an idea in terms of where they are, what their thoughts are about being pregnant, whether they use condoms or not, and if they use birth control. Childbearing plans is what I was alluding to in terms of whether or not they're planning on having a child in the near future. To a teenager, 20 is old, very old. So they don't, and also they're, the fact that a lot of teenagers don't feel like there's a chance they may not live to be 20 or 25 because of the threats that are out there for them. The history of sexually transmitted diseases, you want to know about that. If they've had a sexually transmitted disease once, the likelihood of them having it again is high, so you definitely want to make sure that you screen this particular person a lot more than you would someone else. And this is when I said that you may feel uncomfortable yourselves asking certain questions. Sexual satisfaction is one of those questions that people may feel uncomfortable asking, especially on a first visit. But there are ways of asking that without asking, are you satisfied having sex? Does he please you? That kind of thing. Now, you might want to get at it is, do you feel uncomfortable with sex? You know, in terms of when your partner wants to have sex, do you feel like you're ready? Or do you want to say no but don't say no because you don't want to make your partner feel bad? So those kinds of things can kind of get at that a little bit. And then history of survival sex. Sometimes they may have sex just to get paid, get some money for clothes or get some money for drugs or whatever. Survival sex, so it's one way of trying to figure out that. And unwanted or coerced sex. And certainly teenagers don't feel like if they're out with someone that they know and that person kind of coerces them into having sex, they don't see that as rape. They just say they were in the situation, it happened, and they went along with it. So helping them to understand, another teachable moment, helping them to understand. To summarize that prior slide, this slide really gets at it in 5 succinct ways. It's called the 5 Ps. So this is an easier way to kind of remember what you need to talk about when you do a sexual history. Partners, okay, male, female, or both, sexual practices, anal, oral, vaginal, past history of sexually transmitted diseases, pregnancy plans, and protection from STDs if they use condoms. This is a very busy slide, but basically I put this up as a summary to sort of let you know that before you begin your history, you want to really try and establish a rapport with the teenager. The heads assessment is very important that we talked about, using open-ended questions like tell me about or when, because if you ask yes or no, I mean, they're going to give you yes or no answers. And be aware of judgmental questions, like you don't have unprotected sex, do you? Of course they're going to say no. They're going to tell you what you want to hear. Behaviors, like if you ask about behaviors or practices, and at the time you're looking at them and you're frowning or you're shaking your head, they're going to know that, they're going to know it. So be very careful about the way that you respond when you ask the question. Don't ask questions if you don't want to get the answer and give you. So be very, very relaxed and attentive and listen to what they have to say. And they respect that from you when you do that. And sometimes you need to frame the question in a third person. So I understand that teenagers your age are beginning to have sex. Instead of saying, are you having sex? You might want to use third person when you're talking to them about that. And basically you want to make sure you stay away from clinical terms. So if you're going to ask them if they're having sex, are you having sex, as opposed to do you have intercourse? They won't know what that. And they generally won't say, what is that? Because they don't want to feel stupid, so they won't ask you what you mean, and they'll just say no. You really want to listen to them when they talk, paraphrase, and actually one of the important things you don't want to do when you're talking with a teenager is you don't want to use slang with them. They don't want you to use slang with them. That's their own language. They don't want you to be using their language. So be very careful about that. But if they use slang and you don't understand, ask them, what does that mean? And they'll explain it to you. Let's see. So Angela's had sex 3 times with her current boyfriend. She uses condoms, but she's only used it 2 out of the 3 times that she had sex. So what questions do you want to ask Angela at this point? That's quiet there. You want to ask her when she last had sex, and if she last had sex within the past 5 days, you want to offer her, especially if she's not on birth control, emergency contraception. You are going to get a breakout section in which you're going to go over emergency contraception. But basically, What you want to do is you want to ask her, because you want to offer that at this point to protect her from a pregnancy. And the emergency contraceptive pills that are available on the market will prevent an ovulation up to 5 days. There are some that work better than others. There's one called Ella that works as well on the 5th day as it does on the 1st day. But most of them work within the first 72 hours, and the best time to give it is within 24 hours. So you want to ask her if she's having sex, and you want to offer her the emergency contraception. If she hasn't had sex, then you want to do a urine pregnancy test. If she's had sex 14 days or longer, because less than that, you're not going to probably pick up the hormone for pregnancy in the urine. So you want to certainly ask her, and if she has not had sex for 14 days or more, then you want to do a pregnancy test. So I'm going to skip the slide on emergency contraception because you're going to get that. So she informs you that the last time she had unprotected sex was 2 weeks ago. So you do a pregnancy test and it's negative. Do you need to perform a pelvic exam? Let's see a show of hands. How many people think you need to perform a pelvic exam at this point on Angela? Anyone? Very good. You don't. You don't need to do. It's not necessary, not unless you suspect that there's some other issues going on. But if she has no history, no symptoms of sexually transmitted symptoms, then you can sort of ignore that. The pap smear, which would be a reason for doing the pelvic exam as well, is not indicated until she's 21 years of age now, regardless of when she started having sex. Now, there are different organizations that have different guidelines. The American Congress of Obstetricians and Gynecologists say that by age 21, regardless of when they first had sex, or every 2 years. And every 2 years, I'm sorry, up to age 30. The United States Preventative Services Task Force and the American Academy Cancer Society also say 21, but they also say that within 3 years of sexual initiation, whichever comes first. And then for USPTF, it's at least every 3 years if they've had negative PAPs. For the American Cancer Society, they prefer annually. And only if you use the liquid-based cytology test would they say it's okay to do it every 2 years. And the reason for that is cervical neoplasia is very rare in adolescents. And because it takes a long time for them to advance to cancer, less than 21 years of age is probably not, you're not going to pick it up. So that's why they've delayed. And because adolescents will probably not come in for birth control if they have to go through the pelvic exam, it's probably better to delay it for that reason as well. Now, there's always indications for when you want to do a pelvic exam. And so I put this slide up just so you can see that, yes, you can do a pelvic exam for a variety of reasons if you need to do it. And these are some of the reasons that you might want to do a pelvic exam. And especially in rape and sexual abuse, you do want to do either a pelvic exam or a modified pelvic exam on that teenager and during pregnancy. So you tell Angela that there are many contraceptive options that are available to her, and you're confident that you can help her to choose the best method for her. So there's some additional questions that you want to ask Angela about the methods that are available out there. And before you talk about the individual methods, there are some factors that may affect what method you choose for her. So her attitude towards pregnancy would be one. If she wants to prevent a pregnancy, or how long she wants to prevent it, like if she says in the next 2 years I want to get pregnant, then you're probably not going to want to put in a long-term method for her for that reason. Side effects. They have a lot of questions about that. You know, is it going to make me sick? Is it going to cause me pain? Is it going to, cause me not to be able to have children later on in life? The cost of the method, very important. How much does it cost? Will I be able to afford it? Health benefits. How is the method going to help me? Other than preventing a pregnancy, what other benefits am I going to get from it? Peer experience. A lot of teenagers will come in, and the first thing they say is, my friend uses Depo, and she loves it. Or my friend used Depo once, and she hated it because it caused a lot of bleeding and because she gained a lot of weight, and I don't want that method. So they kind of come in with some background on what they will and won't use. And so this is a good time to get at that. There are a lot of myths and misconceptions that they have as well. And you certainly want to sort of get to that point, figure out what they've heard about the method before you help them choose a method. For the pill, for instance, they say, well, it's going to make me gain weight, or it's going to prevent me from having children later on in life. So there are a lot of myths, and this is another teachable moment to kind of go over those myths with them, those misconceptions, to help them to understand the method that they're going to be utilizing. And of course, Dr. Woodward talked about confidentiality, which is very important, because they will not talk to you about birth control if they're fearful that you are going to tell their moms about it. And one of the important things that I do, and especially if the mom happens to come with a child, is I will do a general history, a family history with the mom in the room. Then I'll have the kid undress, and I'll tell the mom to step out with me. The mom comes out, and I just ask her, do you have any concerns or questions before I start the exam that you want to discuss? And moms generally don't. Or if they do, they might say, well, you know, she has a boyfriend, and could you talk to her about sex? And that, because they don't assume that that's what we're going to be doing. So they'll ask that question. And at that point, it's easier for me to have the parent then go have a seat. I'll go in, do the exam, and I'll bring her back in. So that's one way of kind of getting the mom out of the room in a more easy way of doing that. Oh, and partner support. Sorry, that just kind of flew off the screen. In terms of method, you know, a lot of times boyfriends want to be fathers. They want to have children to prove their manhood. So they'll want their girlfriends to get pregnant. How supportive are their partners about the method that they're going to go on? Okay. I think that's it. Okay, I think that's it. I think I finished early.
You were perfect.
Did I?
Oh, there are
good.
some questions.
Yes.
Hold on, let's get the mic.
Thank you. I had a question about condom use. You showed a slide with a very significant increase since the 80s. My impression, and correct me if I'm wrong, is that that's not the case for male who have sex with males because of the improvement in mortality on AIDS. So do you know if there's any data on that?
There is, and I apologize. I did not specifically talk about males who have sex with males and the use of condoms. I know that from experience in working with my transgender youth and my gay male youth, that condom use is not as widely used in some cases with them, and that's a choice that they make, even though they know the risks that are involved with HIV. They choose not to use the condom for various reasons. But I don't have specific numbers for you, and I apologize for that. That's my sister. She's getting ready to ask me a question.
My question is, for HIV-infected youth, at what point would you begin the pap smear for them? Is there any difference?
Thank you very much. It's a very good question, and I did omit that. For HIV-positive adolescents, we actually do pelvic exams. It's required every year. We don't follow, the guidelines specifically say that if they're HIV positive, they definitely need to have a pap smear every year. The reason that we specifically need to do that is because I had an 18-year-old that was referred to me from an adult hospital because she had gone there. She had STD or I can't remember now the circumstances either. She was pregnant. She had a pap smear that showed precancerous, well, cancerous cells. And they happened to do an HIV test at the same time, and she was positive. So the advancement from precancerous lesion to cancerous lesion in an HIV-positive female can be as low as 3 years. So it's very, very important that you do annual PAPs on them. So thank you for that question.
Any other questions for Carlene? Oh, one over here.
Thank you. It's more a comment than a question. The DC just released its latest youth risk behavior survey data, and there's a whole section on LGBTQ youth. We don't have a good T question yet, so we don't have data on our trans kids yet. But I'm sure the condom use and young men who have sex with men answer is in that report, OSCE.dc.gov.
Oh, DC what? I'm sorry.
It's the DC Office of the State Superintendent for Education that administers the biannual survey in DC schools. So it's all DCPS and all charter schools combined data. And there's a whole LGBTQ section in the report for the first time, OSSE.dc.gov.
Thank you so much.
Thank you.
Thank you.
Any other comments or questions? Okay, thanks, Carlene.
Thank you very much.
So this is the time where we want everybody to get up and stretch their legs. It's officially break time. If everybody wants to peek at their agenda, thank you. I will just quickly review how this is going to shuffle along. Those of you who are interested in, or let me be more clear, if you have pre-registered and I gave you a pre-printed badge, then take a look on your shoulder there and you'll see what you have been assigned for the first breakout session. If that session is emergency contraception, then you'll return here for a start promptly at 10:15, and we've been doing pretty good on time here. So you'll have 20 minutes to stretch and move and talk with colleagues. If you are interested in going to the OCPs, PATS, Ring, Oh My lecture, and that's where you've been pre-assigned, then for those of you who don't know where you're going, to the 5th floor classroom A, if you're in that corner over there with Dr. Zayed standing up, there's some snacks over there, and then we have people who will assist you to get to that floor. And if you are headed to the Deborah Provera and long-acting reversible contraception lecture first on the 6th floor, then in the other corner, Sonia has some snacks and waters over there, and we will assist you in getting to that floor. 20 minutes should be ample time to get up there. We also have a security person to help batch people up into the elevator directly if we need to scurry. For those of you who have a handwritten badge, then dealer's choice. As long as there's a chair in the room, then you can go. For those of you who have not yet picked up your badges, they are in the corner with Sonia over there in the lit corner. The community resource table that has Dr. Woodward's handout is in the opposite corner, just to confuse you. And bathrooms, as well as the cafeteria, are located on this floor out the door to the left. The elevator bay is just to the right. And each floor, both 5 and 6, have bathrooms centrally located right next to the conference rooms. So you can make your way there. And, of course, we can't eat in here, so I ask that while you're stretching your legs, we do it sort of towards the hallway or outside or on your way to the next place so that you have time to talk and eat at the same time. Thanks for making this morning so great, and we look forward to good breakout sessions with lots of small group participation. Hey. I made a few changes. Okay. Let me just check Brandy. If she made a few changes, can she pop those in? Yeah. She just needed to release lock your thing. Brandy's going to help us with all the AG stuff. Perfect. How are you doing? I'm good. Good. I'm excited that you guys are here. Represent. I was like, I'm graduating today. I also because it's good for me as well. It's like, because you realize, you're like, yeah, you're like, I don't really realize some of the things that you're saying, you know, with the latest updated information. It's really good. Yeah. Good.
Good. Well, we're excited. And last week we were able to, Brandy helping us with the services WebEx. So this is live, or I should say live and recorded. And then we'll send out the link to those people who couldn't make it for like CME credits. So excellent. There's a little necklace that we'll have you wear. You don't have to put it on just yet if you want. We've been good with time, so we'll start promptly at 10:15. Would you be in this room? I don't have any watch today, so I can do that. Oh, we can definitely give you like, I can leave my phone up here. Yeah, which, just grab it and drag it to the desktop. Do like a 5-minute warning or a 10-minute warning? What's your 10-minute session? Okay. We can make that work for sure. And then, of course, there's snacks and water and things like that. Thank you. I don't know which one. Yeah, it should be. Well, it's usually this one on my thing. I don't know. It usually looks like that. It looks like that? Yeah. Hi. Alrighty. You're welcome. Your next session, I could tell you I have to skedaddle out because I have a 10:30 meeting. So okay. That's just the way it is. So sorry about that. I'm Jennifer. I work in the ER here.
Hi, nice to meet you.
Nice to meet you.
You went fellow who's graduating today.
Yeah, congratulations. And you're going to Cincinnati. And you did 2 years of fellowship.
2 years.
Yeah, I was like, how are you leaving now?
Yeah.
Is it because you already had a residency?
Yeah, so I did residency at OBGYN.
Yeah.
And then that's 4 years, and then that's 2 years of fellowship. So.
And you can be board certified in 2 years? Mm-hmm. Got it. Okay.
So it's actually not ABOG approved or accredited fellowship yet, but they are moving towards making it such because it's becoming, people 10 years ago didn't see the need for pediatric oncologist, and now it's become like
it's so great here how we have.
And so they're moving towards making it.
We always just kind of made guesses before.
Yeah.
You know what I mean? Now we call the residents so often.
Yeah, and the residents are really good.
Really good.
I actually prefer it because, we take calls 24/7.
Yeah.
So when I had a resident rotate with us, and they go to the ED, I feel like they know what they're doing, they know what they're looking for.
Truly.
So I really found that having them rotate with us is something for them going forward. Because they're going to be generalists, and they're going to get these little girls, and they're going to do the wrong thing.
And honestly, it's shifted our plans a lot in the ER from what we would have done without the resources.
You guys are great in the ER, I would say. You guys are really great.
We know how to spitball big things. I have to say, there were things where, it was obvious one way, and Dr. Gowen's logo was or not. And we were like, ew.
And that's the thing, because,
and it was, amazing. It was...
It's funny. It's all based on, the training. Because there are things clearly that we don't know. We don't know about the medicine behind peds, but we had to figure out paratotal torsions, or even the general surgery thought it was something in the, the omentum or something. We're like, no, it's a paratotal. We're very comfortable looking in.
Well, yeah, I think I heard about that. I was like, I've never even heard of that.
Right. And we've never heard of the mesenteric cyst thing. We're like, does that even happen?
Something that's anywhere. That's the lesson I'm getting from that. Yeah, that's hilarious.
So, it's been good.
Well, Cincinnati would be great. Do you know that area?
I don't know the area, but I've been there 3 times, and I actually
like it. It's so confusing. The city's fun annoying, but I don't know. I lived in Columbus. I was at Ohio State for my fellowship in PCM, which is much more relaxed.
City. But I mean, Cincinnati Children is so great.
That's my keep hearing. It's like the gold card in Cincinnati. But I'm making it into my little New York. I'm from New York. I'm making it into my little New York because it
Well, it won't be. The thing is, you know what, having lived in Ohio for many years after fellowship, first of all, the hospitals will be fantastic. So just in terms of work, it'll be great. But we don't have like this very Midwestern value is that you stay close to family. And I grew up in the East Coast, I grew up in D.C., and so you just leave. Like, once you're ready for high school, parents are like, you're not applying anywhere around here. You're going away. But it's not the same in the Midwest. So, like, medical students were like, I'm going to look in Michigan, Indiana, and Ohio. And I didn't understand why. Because I want to be within 4 hours of my parents. I had this over and over again. That's such a crazy thing. Kind of wonderful and kind of bizarre. And so that's, like, probably the downside. But
I'm there for 3 years.
You'll love it. It'll be so stimulating. It'll be a great division. I mean, I don't know division of adolescent medicine there, but
they're really great. They're actually the leading program for pediatrics now.
Wow.
Which is funny because like 3 or 4 years ago, I went to a conference and I saw people from Cincinnati get up there and talk gynecologists. I'm like, awesome.
So wait, you'll be under adolescent medicine or will be under?
No, so we moved to under surgery. We used to be under adolescent medicine.
So you're going to be, you're going to be very specifically a pediatric gynae person. I think, how many places have that? I thought this place was very unusual.
This is very unusual, and for me to get that job, it was very unusual and unanticipated.
Yeah.
So it's maybe 5 programs in the location has completely.
And what does Cincinnati have that like we don't have or the other programs have?
Cincinnati just has a program that's been developed for a much longer time. So they've been there for about 20 years. So they were previously housed in adolescent medicine and had that time to build. They did tons of research. They've moved now to the Department of Surgery, and they do tons of anomalies and these things. But they have a big cachet, like Kentucky. I mean, so they've just been a more established program. So Goldman Global was here. It started maybe 7 or 8 years ago.
I don't know.
Getting a foothold in children. And people are still saying, oh, I didn't even know you guys had a care cell. That doesn't happen.
Right. Funny, I would think it'd be so much more fun to be housed under adolescent medicine surgery.
But the change in that lecture, she was more of a surgical person, and that's when the change.
Well, yeah, it sounds like the kind of surgery that's done. Much better.
I'm sorry, I don't mean to interrupt. This is your
It works really well, by the way.
Yeah, really nice.
Having used it once, so it works.
The only thing you need to do is press the button to turn on the mic before you start.
And then once it's green, you're
it just
But it's super powerful, and you can swivel your head around. So
you can walk anywhere you want, and that way the WebEx people get to hear it.
It's really interactive. All right, nice talking to you.
Well, that's what I was going to say. So this is a really daunting room, and I forgot my masking tape, so I couldn't block people from there. But you're dynamic, I'm dynamic, no big deal. If for some reason I'm upstairs at the start, then what I want you to do is just grab the people and make them come up forward.
Perfect.
Or, because you'll have the clicker, and I actually don't know where the camera is. We can ask. Brandy, do you know how far the range of the camera is for Jill? Like if she were to walk, move.
If I want to put
or is it just her audio plus the side? Oh, so you can roam anywhere.
Okay, perfect.
So great. So you can go anywhere. So in that sense, if you wanted to, people are dispersed like not quite evenly between the three things, and they've changed their mind.
It should be nice small groups.
It should be small, even though the room is big. So if you end up just like sitting, with them in a little circle, cool also.
Okay, that's good.
But I just wanted to make it like as interactive as possible.
Perfect. I was actually planning to tell people to come forward if they weren't anyway, so I'm happy that you told me that. So
I want you to like demonstrably. If you want them like sitting on the floor in a circle.
I was a little icebreaker.
Yeah. But I just don't want you to feel. I feel like there was a risk of you feeling bad that like this room feels so big that if there's only like 6 people here, you'll feel like, I'm a failure. But no.
No, it's okay.
We want it to be small.
No, I was kind of like walking. I'm like, oh shit, I'm in the auditorium. I'm typing in Rachel's one.
I know. They're gonna have their own challenges in those rooms because they are lovely rooms, but they're
not made for speaking.
Not traditionally. One of them is like a little bit longer, and so it's going to come off more didactic unless Peggy she can do it, but like the room vibe is that. The other one, we'll see. Rachel should have better luck with a round kind of room. Okay. But anyway, you've got a few minutes.
I will be in
bathroom.
All right. Good job. Okay, so we'll be done. That was my life I was saying. Yeah, things like our goals and stuff, you go to school, that kind of figure out what is it and why. Yeah, I forget. But I can't forget. And I just double my crap for monthly. Me too, I never forget things. Really? Oh, yeah. I don't understand. I can't reply to honestly. Yeah. Was it? No. Right.
Oh, wow.
Good morning, everyone. I'm going to get started. So the first thing I want to ask everyone to do is come in between the first 4 rows. So wherever you are, come up to the front of the room. Just so it could be a nice small group feel, you know. You coming? Huh? Oh, go there after you, yeah. Okay, can everyone just move up to the first few rows over here? It's a small group thing. Come up. Yeah, to the first 4 rows. Thank you. This is a small group session so we can be more interactive and have a lot of input from everyone. My name is Jalencia Trotman. I am an outgoing second-year fellow as of today in pediatric and adolescent gynecology. This is Dr. Gomez-Lobo, my boss, in front. I'm going to discuss emergency contraception today. This is a very big topic, and in preparing the slides, I realized that you can have an hour-long presentation for any small part of it. So I'm just going to give a basic overview of most things, and at any point, if you have a question or anything, you could just, interrupt. Let's try to make this interactive, and I have a few questions out there. If anyone knows the answers, just shout them out. So the objectives are just to understand the indications for using emergency contraception, to identify the types of contraception currently available in the market in the U.S. and understand their mechanism of actions, as well as to understand what are some of the challenges and opportunities for increasing the use of emergency contraception in the patient, provider, and health systems level. So I'm sure most of you guys have seen these slides before. It just shows that in the developed nations, the U.S. is doing pretty badly with preventing teen pregnancy. It has actually the highest teen pregnancy rate amongst all of the developed nations. Why is that? So about 25% of women and 18% of men report using no contraception the first time they've had sexual intercourse.
13% of adolescents experience a contraceptive method failure during their first year of use, and a failure amongst the adolescents, they're 90% times more likely to get pregnant than an adult woman. Teens using contraception use it very inconsistently. Studies among 15 to 19-year-olds show that about 70% say they take the pill every day, but that number is also grossly overestimated since it is self-reported. And there's almost 750,000 pregnancies that occur annually amongst U.S. teens under the age of 20, and 80% of those are unintended. So these are the reasons why we definitely need a variety of interventions to target this population. The emergency contraception is your final intervention to prevent unintended pregnancy. So this is not your go-to initial method, but something more of your in case all else fails. Teens who get pregnant also have increased morbidity, and this is something else that maybe we don't always think about, but they are at a higher risk of having an infant with low birth weight, developmental delays, as well as a negative social impact later on. Teen mothers have a very low likelihood of graduating from high school, as well as their children, and they are increased probability of living in poverty. So teens are having sex. I think everyone pretty much knows that. So this is from the Youth Risk Behavior Survey 2011. This is nationally, and it just shows the percentage of high school students who personally reported they've had sexual intercourse. And among African Americans, about 60% of those reported that they had it. But you can see about 50% of teens are really reporting that they've had sexual intercourse by the time they're in high school. And this is averaged. So are they using contraception? About 55 and 68% of them claim to use contraception, and this is not reporting what type specifically that they're using, but what we can see is that these are also grossly overestimated. This is all self-reported data from the team. Sexual assault. This is something that we don't often think about with adolescents, but they are at an increased risk of sexual assault compared to any other age group, with greater than 50% of all rapes occurring in young women under 18 years of age. And the pregnancy rate from an assault is about 5%. So this is another reason why emergency contraception can come into play in this population. So what is emergency contraception? And this is when we're going to talk about very basic things, and if you have any additional questions, just feel free to throw it out there. It's a safe and effective way of preventing pregnancy. And what are the indications? Basically, the indications is any opportunity of unprotected intercourse, whether that happens because they used a contraceptive and the method failed, then the condom broke, whether they didn't use a contraceptive method, whether the sex was unplanned or forced intercourse. Anytime there's an event of unprotected sexual intercourse, that is an indication for the use of it. We should definitely go away from using the words the morning after pill. This is how a lot of teens and some practitioners still think of the pill, and it's very misleading. Why is that? So the morning after pill insinuates you have to wait the next day, and after 24 hours you can't use it, which is not true. The pill can actually be initiated immediately following intercourse, and you can use it up to 5 days after unprotected intercourse. So this is an opportunity. If you have teens that are saying, oh, it's 3 days later, that's still an opportunity for them to use it, but they're not aware. Can anyone tell me what are some of the current methods for use in the United States? Anyone? I'll start picking people. That's no one. What are the current methods for emergency contraceptives in the United States? Because there are other methods, but we're not going to discuss the ones that are not approved in the U.S. Perfect. Those are the two dedicated. Okay, and Paragard. And there's one more that has been used for many, many years, so we don't really think about it very often. Yes, exactly. So these are all of the methods that are approved. So basically, the levonorgestrel containing methods are the most popular and the most widely used and the most studied. This just shows that the Plan B, the two-step was the initial one that was FDA approved in 1999 that is no longer on the market, but Plan B one-step, and there's two generics to Plan B one-step. It's Next Choice and My Way. Next Choice has a one-step as well, and My Way is also a one-step. The Ella, which is the anti-progesterone, the Paragard, and the OCPs, the combined OCPs. Of these, the only two that are dedicated FDA-approved emergency contraception would be your levonorgestrel only, as well as your Ella. The Paragard and OCPs can be used, but those are not dedicated products. I just gave you that answer. So let's talk about the most popular. So your progestin only. So the real reason why this is the most popular is because it's really been the one that's been most extensively studied. Originally, it was a 2-dose method with 75 milligrams used the first time within 72 hours and the second dose within 12 hours. There were a few studies that showed that actually putting the regimen together and taking a one-time dose of 1.5 milligrams was equally as effective. The majority of studies showed no difference in side effects. However, one study did show potential for a slight increase in headaches and breast tenderness. But, you know, if you counsel patients about that and they take it, you can anticipate that's not that life debilitating. The dedicated products that are available in the U.S. currently are the Plan B one-step, and that was FDA approved in 2009. And most recently, and I will discuss this a little bit later, as of August of 2013, officially there is no age restrictions or no prescription requirement for this product. This is the brand name product, and we discussed that, why that's an issue a little bit later. They are approved generics, so after 2 years on the market, you are allowed to come up with generics, or companies can make generics. So we have Next Choice and My Way. These two, you still require a prescription for teens who are 16 and under. So they are the same medication, but because you're not Plan B, specifically, you still need a prescription for that if you are younger than 17. How effective is it? So the studies that measure effectiveness, you can't do a randomized controlled trial on this anymore because we know it works. So you have to deduce a lot of the information. So what the exact rates are unknown, but the efficacy is shown to be about 59 to 94%. A lot of the studies compare the levonorgestrel to combined oral contraceptive pills. So that's where you come up with your efficacy. But we do know that it's most effective the sooner it is taken. So this is just a study that was done by the WHO that shows that within 1 to 3 days, the pregnancy rate on the left was about 1.3%, and the studies average around there. Up to 4 to 5 days, the pregnancy rate, although still low, does double in some stores, up to 2.4, 2.6% in one study. What is the mechanism of action? It's not 100% determined, but it's believed that it does disrupt the normal follicular flow. It basically impairs ovulation and causes some kind of luteal dysfunction. It may interfere with sperm migration and function at all levels of the genital tract. That has not been proven in any studies, but a lot of people think that that's probably one of the mechanisms. The effect on the endometrium is also unknown. Studies say varying things. It does have some effect on some of the proteins after associated with the LH surge that prevents implantation. So whether that actually affects it, who knows? So there's no real answer on what the true effect is on the endometrium. That's to say, and we speak about this a little bit later, it has no effect on an embryo that has already implanted in the endometrium. These are all effects before implantation. The next day, and this is the best, the speaker before kind of alluded to the fact that this is misoprostol acetate, or Ella, is probably the best hormonal regimen that is available in the U.S. So it's a second-generation anti-progestin, and it was FDA approved in 2010. It's a one-time dose. This is available only by prescription amongst all comers, which is a significant barrier given that it's, as I show, it's one of the best methods. So why is it the most effective? Because it actually is the most effective at delaying ovulation up until 5 days. There is absolutely no difference in its effects at delaying ovulation between days 1 to 3 or days 4 to 5. It's equally as effective. It has a failure rate of about 2%, and when it's compared to Plan B methods, it has a 65% lower pregnancy rate up to 24 hours, a 42% lower pregnancy rate up to 72 hours, and up to 120 hours. It basically is unparalleled by any of the other methods. So this is a really great option that is really limited because every woman needs a prescription to get this. So, what is the mechanism of action? This is probably one of the reasons why it's not as readily available, because it's not as well studied as the other methods, and there is still some thought as to what what is the true evidence of interrupting cells after implantation? There has been no proven effects after implantation. However, the studies are smaller and haven't been studied as long. So I think in the coming years, people may change their practice based on future studies. But it does have some delay in the mid-cycle LA surge, and it does work after the LA surge as well in preventing ovulation. It has the potential to interfere with the sperm's ability to reach their fertilized eggs, but again, we have no idea how that really happens. So the combined oral contraceptive pills. Does anyone know what is the recommended regimen if you were to use this method? What did you say? Depends on the pill. Exactly, depends on the pill. What is how many doses does a person need? So not what the regimen is, but how many times would they have to take a group of pills, Twice. Yeah. So, and it's, yeah, more than one. So basically, it's known as the Giuseppe method. It was basically kind of discussed by a Canadian researcher. It contains the two hormones that are in OCPs, which you had a lecture on that, so we're not going to go into that. But it's actually a really great alternative when dedicated products are not available. A lot of girls may actually have these pills already. We write a lot of Cristal for some of our girls, so they may actually have this at home. If they come in and they haven't used OCPs for a while and they have a pack of pills, this may actually be something that they can use if you give them strict instructions. The regimen is usually one dose followed by a second dose 12 hours later. And she was absolutely right, and it depends on the brand of the pill. So you're either going to take 1, 2, 4, 5, or 6 pills, depending on what the brand is. But you're only taking it twice. And for the exact regimen, you can go to, it's really small, but this website, the Princeton EDU, it gives you all of the approved pills. There's 26 different brands that are approved, and you can see exactly what the regimen is. Most of the pills you have to take 4 or 5 twice, and you can imagine what the side effects would be with that, which we'll give a little bit later. So it is okay. It's not as good as the other methods, and the efficacy ranges from 56 to 89%. Again, not well studied, really. What's the mechanism? Again, this also inhibits or delays ovulation. It may or may not have some effect on the endometrium. Only older studies done in the 70s or early 80s showed some effect, but the recent studies done in the 90s and the early 2000s showed there was absolutely no effect on the endometrium. So either way, it's not really significant. There are a variety of other possible mechanisms, but none of these have actually been proven to have any true effect. So I think a lot of people always wonder about, okay, so I don't want to give this to her because what if she's pregnant already and what's going to happen to her growing pregnancy? So this have actually really been studied. Zhang did a study in 2009 that was a prospective study where he matched 322 women who were pregnant who reported taking the EC within the first few weeks of intercourse, compared to women who did not, and found that there was no difference in birth defects and birth weight and no neonatal or pregnancy outcome. Looking in vitro models for implantation, there has been no effect in impaired attachment of embryos, and the animal models have not shown any post-fertilization effect. So basically, there is no evidence to show that it's going to be a teratogen or disrupt a pregnancy. So it's really important that this is not the abortion pill, which a lot of people are still sometimes calling it and confusing morning after abortion pill, all these things all lumped into one. How do you compare the side effect profile? So this is something that, again, we think about for counseling. So obviously, if we're using the combined pills, we anticipate we'll counsel girls on nausea, breast tenderness, some vomiting. What about the other two methods? That has also been studied, and as we can expect, the Giuseppe method is significantly associated with the nausea, dizziness, some fatigue. The best side effect profile, again, is Ella, the one medication that's probably the least available to everyone. That's something else you could counsel your population on. There is some question as to whether there is some delay or there is some change in the menstrual cycle after taking lethal progesterone pills or Ella, and it may shorten the cycle, but those studies are still not really significant. What about the copper T? Does anyone know when you should insert the copper T if you're going to use this as an EC method? You answered already. Someone else? Anyone else? Okay, 5 days. Sorry. Exactly. So this picture is really small, but it just basically goes over the fact that you can see from fertilization all the way through the day cycle, the embryo implants around day 6 to 7. So if you implanted within the first 5 days, that's your opportunity to prevent pregnancy. Now, when people hear 5 days from when? So 5 days from they're thinking if you ovulate 5 days from now, that's your opportunity. But the question is, when are you going to ovulate? So the WHO actually said that you can insert up to 12, the cycle day 12. So not 12 days after, but cycle day 12. So if the girl knows when her last menstrual period was and she had sex anytime within then, you can feel free to put the IUD in up to day 12, because in theory, if she has a normal cycle, she should be ovulating a few days later. So that IUD would still be there. She also has a reasonable suspicion that she's not pregnant. So I think if someone comes in and she says, you know, this is her cycle, this is an opportunity to do pregnancy testing for these girls, and this is one of the only indications to do pregnancy testing. If you're going to fudge it and say I'm doing it on day 12 and not strictly by day 5. And this is actually the most effective method for emergency contraception, with reducing the risk of pregnancy by more than 99%. However, there are significant limitations in this population, the risk of STIs, and a big bad, as well as the fact that we're not going to use this as a dedicated EC method. You think of this for long-term contraception, which you have to lecture on that as well, but this is an option. And these are the different mechanisms of action, which someone else will go in later, so I'm not going to go too much into that. So are these methods safe? There have been absolutely no deaths or serious complications that's casually linked by emergency contraception. The thing is, you're taking this really once or maybe twice. So you're not taking it on a prolonged period of time that even if you have medical contraindications to even combine OCPs, you really wouldn't expect that same risk to happen. So the WHO medical eligibility criteria actually says there's no situation in which the risk of using ECs outweigh the benefits. This means girls with a prior history of ectopic, liver disease, cardiovascular disease, anything. The only thing is Ella was not addressed in the medical eligibility criteria. And again, this is something that's very new. So hopefully that would be added to their eligibility criteria soon. So what are the medical complications that are contraindicated? Anyone? I'm happy you brought that up. So there is no specific medical complications, but pregnancy is called a contraindication. And the only reason why it's a contraindication is simply because it does not work. Not because it affects the fetus, but because it's going to affect the implantation. It does not work. So for that reason, it's contraindicated. So not truly like a negative effect. What screening procedures are needed before provision of EC to your adolescents? Guy with a striped shirt on. I'm going to start calling people out. Anything?
I know that, like, where I work, we get referrals for people to get it.
You get referrals?
Yeah.
Okay.
They go to, like, the clinic down the street.
Okay. 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 All right. Does anyone think you need to do a pregnancy test before you give it? So if a girl comes in, she's like, oh, I had sex a few weeks ago maybe, and then the other day I had sex 2 days ago, unprotected. Does she need a pregnancy test before you give it? You say yes? No? Okay. So what does ACOG say and a lot of other practice guidelines? There is no clinical examinations needed. That means no pelvic exams, no pregnancy testing, absolutely nothing. If she's had unprotected intercourse within this time period, then she should have access to this method. Again, because what's the worst that can happen? She's pregnant already and it's just not going to work. So you should not deny for testing, or if she has normal cycles and she reports that she's likely now in the luteal phase, this also is not a reason to restrict her from access to this contraceptive method. So another question that comes up, and I'm not going to spend too much time on this, but I think it's important, when can she start EC when can she start her regular contraception after starting EC? Because we should always be counseling them. If we're counseling them about emergency, we should be counseling them about what they're going to, do long term. Does anyone have an idea how long they should wait before they start their regular method? Exactly, immediately. Is there any potential effects? So the selective practice recommendations from the CDC says that because we just don't know what the risk of the progesterone is in Ella, then she should abstain from sex or use a barrier method for 14 days in addition to her contraception. So definitely start it, but she needs to know that she may not be completely protected. Has anyone truly gotten pregnant from this? No, but just because they don't know, you have to let them know the risk is there. Similarly, for the other methods, they should abstain, but this time for 7 days because they don't have the anti-progestogen. So, a little time for challenges to adolescent access. Anyone have any questions about the mechanism of action, the methods? Yeah. Yes. So they can still use it because it's better than nothing and it's safer than if they got pregnant. So you always want to compare to, okay, what's the worst that can happen? Anything that happens for her taking a pill is going to be doubled by pregnancy. So the risk of pregnancy is worse, and because it's taken for such a short time, if this is so what they say is this: if this is the only method available, then that's what you should use. Otherwise, if you're really successful to have Plan B, Ella, even the IUD, in those patients, the IUD would be the preferred method, but it's just not always realistic. So the answer is yes. When in doubt, give it. Just counsel. Yes. The website, and I'll tell you, let's see. Sorry, it's so small. It's ec.princeton.edu. And if you Google Giuseppe Methods Princeton, that's how you're going to get it. And questions, dose. Okay? So I'm going to move pretty quickly through the next part, only because it's a little cumbersome, and it's a very difficult topic when you talk about policies and barriers, so stop me if you think I'm going too fast or if there's something that I didn't mention that you wanted to know more about. So there are a variety of barriers. There's patient level, there's provider level, which we're not really doing that well at, and then there's health policy and really media level, I think. So at the patient level, not only young girls, but women. In general population, we're just not that aware of truly what the facts about emergency contraception are, as well as 28% of girls reported never hearing about a method, and only about 40% of them know that you should take the pills after, but not before sex. The awareness of Ella is really, really, really very low. I think if you sample most people, they would not take this method as a birth control, as an emergency contraception. They have never heard of it. Patients have a lot of misconceptions. The thing that we always hear is the fact that it is an abortion pill, or they're scared that if they are pregnant, then maybe it'll harm the fetus that could potentially be growing in them. That's another missed opportunity. And as well as confusion over fertility, cycle, and timing. That's why we should really not focus on where in the cycle she is and not use that as a barrier. So if you see her grow in your office and you say to her, well, I'm not going to give it to you this month because you likely ovulated 4 days ago, she's going to have some miscommunication. So maybe the next opportunity that she does this, she's going to miss that opportunity to use this medication. So we should really not focus on what the timing of her cycle is. There's a perceived lack of confidentiality for our teen girls who don't want their parents to know that they are, sexually active. There's a lack of money and or insurance, which becomes a big issue later, even with the OTC guidelines. It actually shot the price of EC way up. Lack of transportation, getting to their pharmacies or their physician's office to get the medication, inability to locate a healthcare provider, the belief that they need to have a pelvic exam in order to get the pill, and some over-the-counter exclusion to minors, barring Plan B at this point. And all these barriers are really, we should tackle these things when they come to their well-adolescent, well-teen visits. This is the opportunity to hit all of these barriers before they ever need, hopefully never, but before they ever need emergency contraception. So these barriers can be easily handled, provider level. We're actually not doing that great ourselves. So of pediatricians with adolescent patients, only 20% reported prescribing emergency contraception, and 24% reported counseling adolescents about EC, and this was way before it was even over the counter, and these numbers are really low. They haven't changed much over the course of the years. Providers actually need more training because what happens, we really don't get trained for this thing in residency as part of our group practice. There was a survey done in 2001 that showed that about 73% were unable to identify what the FDA-approved methods were. So if you're counseling a teen in your office about this, how can you give her all of the right information if you just don't know the information yourself? The problem is this is not something that's on the front page. Like we hear about there's different things, HPV vaccine, this and that. Emergency contraception is a taboo subject, and for that reason a lot of media outlets don't want to propose it and tackle the issue. So as physicians, it's really our responsibility to keep abreast of what's new, what's the current information. There was a recent survey, 2008, that showed 1 in 5 practitioners are reluctant to provide the education on EC to teens that were sexually active. Now, this is obstetricians and gynecologists, pediatricians, as well as family health care providers, and they mainly thought that if I give her education, then she's going to go out and have sex and she's going to need it, so I'm doing her a disservice. Another study found that, so they wanted to know, well, why are pediatricians not really prescribing this? So 22% believe that it encourages the risk-taking behavior. About 50% said they would give it, but they would only give it maybe once or twice. Very few cited religious reasons, and about 17% were concerned that it actually does have teratogenic effects on the fetus. Unfortunately, only 21 to 50% of female sexual assault adolescents even get EC or are offered EC in the emergency department, and this is something else that really is mandated by a lot of state legislature, and this is another place where we have to truly target a major barrier. So I think education, education, education. So basically you need to target teens before they ever need it. You need to talk to them when they don't want to hear it. No, I don't have a boyfriend or a girlfriend, because you should also be speaking to boys about this. I'm not interested in having sex. That's a perfect opportunity to talk to them about emergency contraception before they ever need it. So advanced prescriptions is something that's actually recommended by a lot of healthcare organizations with multiple refills, and they actually recommend you give them 12 refills of this, okay? I know some people may say, oh, you're maybe encouraging stuff. Studies have not supported that. So if a teen comes in and she chooses a large, clearly you're less likely to give her the script. She may not need it, right? But if she's choosing nothing or a condom, birth control pills, patch, anything, it's okay to write her a prescription, especially for Ella, since we do know it's the most effective and the least accessible for her. Have her get it, put it in her drawer, and leave it there. She may never need it. You should discuss condoms and assess for risk for STI. You should never use this as an opportunity not to counsel. You should definitely use this to counsel teens on things before it really becomes an issue. Explain to them that you don't need a pelvic exam in the future if you need it, and explain that it's not an abortion drug. I think once you tackle these things with teens, they're less hesitant to not use it if they need it. You should always train your office staff, because these are usually the front line. So a girl may call the office and say, I need to get to my doctor for EC, and the office staff may say, depending on who your staff is, oh, you're not available because you had sex more than 3 days ago or something like that. So you should really train your office staff on what the practices are, as well as if there are any age restrictions to the medication. This is an excellent website for everyone to have, as well as to give to your teens, because this is really user-friendly. So www.nottolate.com, you go on there, you can put in your zip code, and it's going to tell you where the closest contraceptive methods dispenser of EC would be. It's also going to tell you the pharmacy number. It's also going to list a group of physicians that give emergency contraception. So physicians should really put themselves on this list if they are willing to prescribe this to the teens. It's very user-friendly, and it's monitored by the CDC. Another thing is basically advertising in your own office. Put up, these posters or a little pamphlet. Identify with the teen. Okay, so if you needed to have this, do you have a way to get to the prescription? Do you have a way to get to the pharmacy? Do you have money to pay for it? That's another big barrier. These are things that you really want to discuss with them beforehand, and these are even more reasons why they should basically have the prescription in their drawer when they need it. So instead of buying the new iPhone, maybe the first check she takes and she puts it in her drawer and she buys the iPhone with a second one. Does it increase risky behavior? I'm going to run through this. My time is almost up. But multiple studies have been done, and it does not increase risky behavior. The only thing that advanced provision or over-the-counter access to this method does is increase its use. So they're no more likely to miss a pill, they're no more likely to switch, they're no more likely to forego using a condom. All the same things there. So we really recommend that, they really want to push the fact that you should really be giving teens these prescriptions for them to have, as well as a prescription for the Plan B, because as we discussed a little bit later, that Medicaid doesn't always pay for the prescription, for the Plan B if it doesn't come with a prescription. So you can't just tell her, go to the pharmacy, you need a prescription, because if she has Medicaid, she may have to pay $60. And then she's not going to use it, and then she's going to get pregnant. So what about the STI risk? So we all know it does not protect against STI, but this is on us also to counsel our patients on that as well. And even the FDA says, you know what, the label clearly states that it doesn't protect against STIs or HIV, so it's a non-issue. We should not be we should not use this as a barrier for access. Health systems public policy. This is a 10-hour lecture within itself, so we're going to wrap it up in 5 slides. So let's think about this first, like, what do we know? Because I want to see, well, what could their concerns be? All right, so we know that it's safe for over-the-counter sale to all women. We know that it's improved access, prevents pregnancy, especially for young women who are at an increased risk for unintended pregnancy. We know that it does not lead to riskier behaviors. We know that it doesn't increase sexual activity. We know that it does not affect a fetus. So, and we also know that all these health organizations agree that we should have unrestricted access. So what is the problem? And the answer is we don't know what the problem is. So although the FDA is a funny beast because it definitely tries and has made great advances in the provision of this and trying to reduce barriers. However, throughout the course and the history of the emergency contraception, and I do recommend everyone go on and look at the history of this medication, you would see that they're bipolar at some point, they are for and against themselves at some point, and it really depends on what the interests are. The Health and Human Services as well, they have been a barrier at some instances. State legislatures, so even though the FDA says you should give this to all women, there are no restrictions, there's no reason to limit it, they still leave it up to the states to decide what their personal access is. And more importantly, Medicaid, our highest risk population, says that every state should have their own plan as to what's accepted or not. So the drug companies also, as soon as Plan B became over-the-counter, there you go, it was $35, now it's $50. So pro-life groups also really market it as an abortion pill. I looked online yesterday to see what was still there. It's still called an abortion pill up to yesterday. And the media doesn't really, I've never seen a commercial for this. Have anyone seen a commercial for this? So we've seen it for the IUD causing like perforations and all types of things. You never see, the truth in the media. So this is a slide that I summed up in about 10 bullet points about just really quickly what the history was. So in 1999, the FDA approved Plan B. This was a 2-dose. In 2006, they approved it for over-the-counter use, originally for 18 and older. 3 years later, after a lot of fighting and a lot of, the courts finally put their foot down and said you have to now open up the access, because basically what they did was the drug company asked the FDA, well, what is your purpose for preventing this from being open? Like, what evidence do you have? And they had no evidence. So the court finally said, you know what, let's just give it. But we'll do it 17 and older so everyone's happy. In 2011, the drug company again filed an application to remove the age restrictions only for Plan B one step. And this is why this is the only one that's available, because that was the language used in their application. In 2013, a federal judge asked both the HHS and FDA why they're not, going along with letting everyone have access. Again, they had no reason, so the federal judge says, well, you have to have it open to everyone, this particular drug. Unfortunately, both the FDA and the HHS and the Department of Justice actually filed like a stop because they wanted the judge to readdress it. But
in August of 2013, everyone dropped their lawsuits and said, you know what, we'll make this one medication available. All of the generics are still prescription for girls 17 and under. And this is the one that's the most expensive. So we still have the continued barriers. Plan B is available, but it's the only one. And there are unintended consequences of the OTC access, because what we have now is that we potentially have girls who never come to the physician and they can go. They're bypassing that all-important counseling, because that's the real point, right? You know, she had an accident, she took the pill, but now she's missing the STI counseling, the LARC counseling. So this is something that some of the people against it are using as, well, what are you going to do about that? And this is why I say in her healthy teen visit, you need to address these things then. The one-pill generics may be available, but those are always going to require a prescription for 17 and older unless the laws change. And Ella is still requires a prescription for everyone. Really quickly, the states basically do their own thing with it. There have been great improved access. Basically, there's 26 states that's really for it, 19 states is really against it, and like a few in the middle. D.C. is really like in the middle, but in D.C., everyone that has had a sexual assault must be offered emergency contraception in the emergency department, and that is a law. The pharmacies are required to stock a lot of the contraception now, and the pharmacists cannot make their own judgment call as to whether a 17-year-old presenting for this should get it or not. So these are some of the ways they've gone to improve access. While some states have basically said, you know what, the pharmacies can refuse it and they don't have to stock the prescriptions at all. And everyone have access to this. This is on group markers, so you can look on and see what the states say, and they always put DC in the bottom, like this 50 states plus DC. So. The cost and coverage of Plan B fell from between $35 to $60, and this is a major barrier if they don't have a prescription, because although Medicaid covers this prescription in 26 states, if you don't have a prescription for some of them, and I looked at what I saw for DC, and this, you know, correct me if it's changed within the last few days, but Medicaid only covers this pill if you have a prescription in DC. So Maryland, on the other hand, you don't need a prescription, but they're only giving you you're only allowed to fill it once within 90 days. So if they're not limiting the prescription, then they're limiting how often you can fill it without a prescription. And the Affordable Care Act actually requires that the private health insurances cover all of them. But if you don't have a prescription, then you're going to pay the retail price. So there it is. All right, and then just want to end up with Ella, that this is really one of our best methods, but we just don't know about it. Providers doesn't know about it. The cost is higher for it. Everyone requires a prescription. There's actually a website that you can go on to get it without seeing a doctor, but it's a little shady, so I can't, recommend that website. So, EC is safe. Everyone should have access to it. We should discuss it and give it to our teens before they ever need it. Plan B is the only one that's available without any age restrictions, but there still continue to be significant barriers at all levels. And I have some resources here that I think you guys have access to, and that's it. Any questions?
Thank you. Hold on, let's use the microphone.
Becoming pregnant and then their children also not having access to higher education.
Right.
Was there a specific statistic on that? I
yes. So, it's hard to give 100%, but 38% of teen girls who have a pregnancy do not graduate from high school. There are no exact numbers on the likelihood that their child will also not graduate from high school, but I think somewhere around 40 to 50% stay in poverty, and this is generations. So, but 38% of girls would not graduate high school.
For Ella, do you expect in the years to come, as there is more research, the courts to eventually intervene in the same way of being if you don't have a reason, then it should be OTC?
Ella is going to be a little bit harder. Now, around the world, there are some countries who are very progressive. Those same countries with a much lower teen pregnancy rate than ours, they have full access to these things. But the problem with Ella is that the studies just cannot prove right now that it doesn't affect implantation. And until we get one or two good studies that says that, like the other medications, I think we have to cross that bridge first. But I do think within the next few years that that's something that will come to light. But we do have that one roadblock. It needs to be more extensively studied. It's also not even on the WHO MEC yet. So, you know, I think it has to go through those steps first and prove it, have like 5 or 6 years of no negative effects before it goes through.
I have a question. You talked a little bit about advanced prescription, or you had one slide about that. And certainly in the Adolescent Health Center downstairs, we try to change the culture around emergency contraception, normalizing it, prescribing it, maybe even informing parents, let alone their children, universally about the concept of emergency contraception and, hey, here's a prescription, I hope you fill it and the box gets dusty and you never need to use it, but just in case. And so do you think that similarly maybe providers will have a quicker uptake of something like the ulipristal, the Ella? You know, we're already trying to change the culture to get clinicians doing that advanced prescription for everybody, but which one is a different story.
So, and you know, so we do need better uptake by our providers. So first we need to educate ourselves and our colleagues. And, you know, if I was providing one, I would provide Ella because it's more effective on a daily basis and it works for the longest period of time. So, and you guys really are the first step to these teams, because as gynecologists, we really see them after they have a specific problem. It's rare that we see them for routine, adolescent checks. So when they're coming in for their school physicals or their health checks or their annuals, this is really the opportunity to get them, because we only see them after either they're pregnant, something has failed, they have an STD already. You know, it's really you guys that could affect the most change with the emergency contraception.
Thank you.
Thanks. All right.
So everybody has 15 minutes to make it to their next session, schmooze with their colleagues, and I encourage you to start your evaluations. It's the colored pieces of paper that are in your folder. We'll be nudging you all day about those. They're very important, available for more questions. If anybody is interested in moving next to the OCPs, patch, estrogen-containing things, oh my, that's on the 5th floor. We take the elevator and I can help you get there if you need. And if you're interested in the depot and long-acting reversible contraception talk, that's on the 6th floor, and those will be starting promptly at 11:15. After that, it'll be lunch on the 5th floor, which is in your agenda, and will be available for questions.